Excellent. So like you guys said so generously, I'm Elizabeth Nugent, and I am both a gynecologic oncologist and a palliative care doctor. And I went back to fellowship about a year ago because I felt drawn to try to provide both kinds of care to our patients. So I'm going to try to show you a quick overview. And like we said, let you get on with your day. So my goal today is to talk about symptom management during cancer and the role of palliative care. Also to discuss some simple tips, which Sherry already shared with us just a few minutes ago. So many of those are key to the simple tips I'm going to cover. And then I'm going to open the floor up to questions. So the first question is kind of what symptoms do patients experience during and after their cancer treatment? So the answer at the end of the day is a very wide variety of symptoms, as I know many of you women can attest to. So there's always physical symptoms, but there's also mental symptoms, sexual symptoms of just a great variety. And as you guys also know, that these symptoms affect you guys, but they also influence the people around you greatly, your loved ones and your friends. So it's not just something that you personally face, but it's something that everybody is trying to face with you. So the next question is, am I the only patient? Am I the only one that's struggling with these symptoms? And the answer is absolutely not. As many people have shared and many people have experienced, the majority, almost 100% of patients deal with bothersome symptoms. You can see that the data I'm quoting shows greater than 90% of patients with recurrent disease have bothersome symptoms associated with it. And those are physical symptoms, but more than a third of patients struggle with mental health symptoms as well. And I know you've heard a ton about mental health today and how important it is for your healing and your journey. You can see it's very important here too. So this is a study where they looked at patients with recurrent ovarian cancer and asked 52 patients to detail the symptoms that were associated with their disease. And you can see of the 52 patients that were involved in this study, the vast majority of them had symptoms, and that those symptoms covered a huge range and type. So you can see this colorful rainbow of things that people experienced during their cancer treatment. So you can also see when patients documented the symptoms that were most bothersome or most troublesome to them, they personally documented those, and then they talked to their doctor about them. So the patients were in blue, the doctors were in red, what their doctor said in their medical records, and then in green is the interventions that were provided. And you can see that these are pretty different. So, and here is another opportunity for us to view the same data. So again, symptoms that patients report, and then the symptoms that their physicians report. So I think at the end of the day, when you look at this, you see that these are different things, that the doctors and the patients are on a little bit different page. Some of this is because we as doctors, as gynecologic oncologists, feel more comfortable treating the symptoms that you can see on the right side of the screen, but patients are really more troubled by the ones on the left. And that is where I feel like palliative care can really help. So what I'm saying is that this is a communication opportunity. This is an opportunity for palliative care to step in and be part of your treatment team and help you with some of these bothersome symptoms that you may or may not feel like are being appropriately addressed. So what is palliative care? So basically, this is a medical specialty for patients with serious illness, and it doesn't have to be cancer, heart failure, renal disease, all sorts of serious life-limiting care. And the cornerstone for what we provide is a team approach to your medical care. So we inside palliative care represent a team to try to help you. So this is a board recognized specialty relatively recently, 2006, but the modern concepts of palliative care in the United States started in the 1950s, so a very long time ago. And our goal was to manage total pain, which we'll go through in a minute. And the other thing to remember that's really special about palliative care, you can enter this field from about 12 or 15 different prior specialties. So people have a very wide variety of experience before they've really developed this passion to take care of patients with life-limiting illness. And it really provides a new or fresh perspective for your care, which is sometimes really important. So you can see that the care team involves lots of different providers, lots of different areas, both of medicine and not medicine. And then we wanted to talk a little bit about hospice versus what palliative care is. So remember that palliative care is for anyone who has a serious illness, but there's no time-limited expectations. You can still get treatment, you can still be hospitalized, and you can still get very aggressive care, and it doesn't preclude you from having the opportunity to take care of your other medical problems, your other medical needs. It's just something that you layer on top. So you can see our old treatment model versus our new treatment model on this slide. So you can see that the original model was that we tried to fix your cancer, tried, and then you move straight to hospice. You can see on the right side of the screen that we are involving both services and both parties kind of throughout your cancer journey. So we're always going to try to fix your cancer. Absolutely, that's always the plan. But as that becomes less and less possible potentially, you involve palliative care more and more to try to help manage your symptoms while you're managing your cancer. And then eventually you may choose to go to hospice care. So the next thing you can see here is my two hats to remind me to tell you my personal story about palliative care, and then to talk about how palliative care can really help you. So remember, the focus is on trying to feel better and assessing your current symptoms, how you are feeling today, your person. We don't really pay attention to, I'm calling them distractions here, although I obviously know those are very important pieces of your treatment. But during your visits, we're not worrying about whether you're having surgery or not, whether you're having chemotherapy or we need to change your regimen or what labs we're ordering. Mostly we're looking at being person-focused and less disease-focused. Our visits are typically longer and they typically involve more people, COVID permitting, obviously. So, and the reason I have these two hats up here is I kind of had this dream after I stopped being or transitioned from being a gynecologic oncologist primarily to being a palliative care fellow again. I'd hoped that I would be able to magically integrate palliative care into every one of my cancer visits, and that I would be able to create this perfect symbiotic relationship between these two things. So I'm sad to say I have not figured out a way to do that. I am certainly trying, and I'm now back to being a gynecologic oncologist again. It's still very important, but I basically feel like I put on my palliative care hat and I take it off and I put on my oncology hat. So my point is that I think that there's a role for both, that there's an opportunity for both, and hopefully over time we'll be able to do a good job of integration. So the symptoms that palliative care can be involved with are these. You can see it's a huge list. The things I think we're particularly well suited to do are pain treatments, especially in patients who have complicated regimens, high needs for pain control, or who have multiple allergies, and also trying to kind of think about all the different ways we can integrate symptom control with your cancer care. And you can see in this, I have the skunk at the picnic, because I think a lot of the things that palliative care gets a bad rap for are for the other things that we do, talking about out-of-hospital DNR, DNI, advanced directives, legal paperwork, MPOAs, things that sometimes are uncomfortable for people to talk about. But the first statement is the most important on the top of this slide. So really, at the end of the day, our goal is to help you meet and do the things that are very important for you. That's really my goal at the end of the day. I want to do what you think is important. And we're going to use all the tools in our tool bucket in order to do that as best we can to help you. So this brings us to our tips, and I think you will have heard a lot of these tips today, so I can sort of breeze through them because it's a review of what you've already heard, and that tells me that it's very important and that you know it's very important. So number one is to work on communication with your physician. So if your doctor doesn't know it's a problem, like we talked about on that first study, then that problem will never be identified or solved or taken care of to your happiness or liking. The other thing is to write it down. I know every one of you, cancer or not cancer, when you go to the doctor, you forget to ask some of the questions that you wish you'd asked, or your visit gets derailed and you don't get the answers that you really want. So having an opportunity to write it down and go through your questions is really valuable. And also if you can bring someone with you or an advocate. I need an advocate at my doctor's appointments. Everybody needs to have that extra person that's got their best interest in mind. So that brings me to the other tip, which is that every member of your team has an assignment. So one of the things I've noticed, and I'm sure you have too, is that everybody around you wants to help, but they don't exactly know how to do that. So they usually give you this phrase, the stock phrase of let me know if you need anything. But unfortunately, what this does is this puts the burden on the stressed person to figure out what they need. So they have to figure out what they need and who they want to ask to do it and get it coordinated. And it's a lot of effort for that stressed or sick individual. So what our goal is, or my thought is that you choose your group of people and that everybody gets an assignment. So you can see, number one is that you use people's strengths. You would do this anyway, but it's an opportunity for people who are really good at any one thing to help you with the best of their abilities. And this is where you're going to choose your advocate. You're going to take your advocate, be that someone who's a physician, who's a lawyer, who's outspoken, who's your best friend, who knows you well, whoever that is, choose your advocate from your team and bring them with you to your doctor's visits or when you need that help and that extra assistance that they're there for you. So we're going to talk a few minutes about symptom management, just the pearls. Obviously, we can't go through it all now. But the first one is nausea, and I like to remind patients who've been through long bouts of treatment with chemotherapy that nausea is very complicated and it involves lots of different organs. It involves your brain, it involves your intestines and your stomach, and it also involves your ears. And the nausea we have during chemotherapy has to be managed different than the nausea that we have when you have peritoneal disease or problems with your stomach. Those are different things, so don't be afraid to experiment with something that might have not worked in the past or something new. My next topic is always, my soapbox is about pain. So we know that pain is a huge problem for lots of patients with cancer in general. So we know that more than 2/3 of patients with metastatic cancer report having pain, and the patients undergoing treatment frequently have pain as well. And we know that it greatly impacts your life. It impacts your satisfaction with your care. It impacts your satisfaction with your doctor. It impacts your ability to actually do your cancer treatment in the way that's recommended. And it impacts at the end of the day how much time you interact with the hospital and doing things you may really not enjoy versus spending time with your family. So these reasons alone, it's a very, very important cornerstone of your treatment. So there's a lot of barriers, unfortunately, to good pain management, and these are ongoing and ever changing. So you can see I have the list here, and then we can talk a little bit about them. I won't belabor them, but you guys know about increased abuse of narcotics and narcotics-related deaths in the United States over the last 10 or so years. And we know because of this, as a reaction, we have created many more regulatory barriers. So there's a national management of narcotics system that we all have to log into and prove that we're doing right by our patients to try to do best for them and minimize narcotics that get out into the world. And also we've created many more barriers with prior authorization. You guys know you don't just get to go get the narcotics that I prescribe. There's all sorts of hoops that we have to go through for your insurance company. Also, one of the things that we always worry about in palliative care is how much time clinicians really spend learning and managing pain medicine. So with all of our maintenance of certification and the testing that we do, there's overall about an hour, 1 to 3 hours of time spent yearly working on narcotics. And we worry, I mean, people spend hours and hours working on chemotherapy. In some ways, it's equally as important, and we just need to bring it up to the level of importance for additional physician education. And lastly, I know that you guys know this too, the cost and ease of obtaining pain medicines is just going up and up. The ease is going down and the cost is going up. So this is just an ongoing problem. So one of the things I talked about a little bit earlier, that palliative care was designed to embody and treat this idea of total pain. So the pain we've been discussing is physical pain, just the yellow pie up at the top, but you can see that there's other areas of pain, psychological, spiritual, and social. These are all very important. And the reason that we have the well-rounded team that we do is to try to address many of these issues. I think you guys have probably already seen this, you're very knowledgeable, but it's the idea of how to manage chronic pain or cancer-related pain and you would start at step 1 and go up to step 4. This is the pain ladder. So one of the things I wanted to bring to your attention are that the pain ladder for cancer patients may be a little bit different. So number 1, you can see I've just covered up step 2, no step 2. So the idea is that maybe cancer patients should skip weak opioids and go straight to stronger opioids. And also you can see at the bottom layer of the ladder has been increased because it talks about using additional medications that can treat pain and symptoms related to pain throughout, not just with narcotics or just with other medications. So don't forget the changes to the pain ladder that particularly apply to you. So the other important things to think about are that narcotics are good for managing pain, but they have serious side effects, and that providing education about those is part of our job. So the number 1 most important thing is about constipation. We'll cover that in a few minutes, but also they can cause nausea and vomiting, sedation, and other neurologic effects. So these 3 things are expected. So the constipation will be long-standing, that will be permanent and associated with narcotics. The other 3 are things that should improve over time, and within a week, you should see substantial improvements associated with these. So remember, constipation is constant, but the other 3 should improve with time. So don't give up on your narcotic regimen early. So treating constipation, you can see my Benjamin Franklin quote here, "An ounce of prevention is worth a pound in cure." So the goal here is that you should treat constipation very aggressively and from the very beginning. People feel terrible with constipation, and if we can treat it and keep it from being a problem, stay ahead instead of behind, it will really improve your experience in general with your cancer care and your symptom control. So one of the things also that cancer patients struggle with is a decrease in appetite or interest in food. So I always try to remind people, and maybe even more importantly, to remind their families, that is how many of us show that we love people and we care about them, that feeding them is showing your love. So this is very difficult to change, but how are some of the ways that we can manage it? So you guys know these things already, but I just wanted to reiterate. So always eat what sounds good. Eat small, frequent meals. If that's 6 meals a day or 8 meals a day, that's great. There's no rules about 3 meals a day. Don't eat diet foods, diet Jello with 3 calories in it, or diet Coke. It's not worth it. If you have a small volume of intake, make sure it really counts. And also on the flip side of the coin from the diet literature, we know that when you eat with friends and family, it's kind of like a distracted eating. People tend to eat more. But on our side of the coin, people tend to eat more with others. So making it a social experience all around may help you to eat more. So our next thing is everything in moderation. And I think this is probably a rule for life. It's not necessarily a rule for ovary cancer or any other kind of treatment, but an important rule for life. And I just wanted to bring it up one more time, that many people make sweeping changes to their lifestyles at the time of their cancer diagnosis. And some of those are really great and so important for your care, and some of them may be going a little bit too far. So everything in moderation. So the things you really should do: stop smoking and stop excessive caffeine and alcohol use. You should definitely continue doing exercise like we just talked about with Sherry. Continue to do work if it contributes to your life in a positive manner, and continue to spend time with your friends and family. All the things that we just talked about. So remember moderation, especially in dietary changes. I have some patients who come to my office and they have gone on a diet where they're eating only mango smoothies, or they're limiting they're doing alkaline or acid diets, very specific things, and really limiting their food or variety of intake. And I worry that when we do that, that we're losing some of the general beneficial effects of a high variety diet. So that's important. And then I know we just talked about supplements, and many supplements are great, but just make sure you talk to your doctor and make sure you're not eating supplements and filling with supplements for the at the exclusion of high quality food. So there are lots of ways that we can manage fatigue. And as you guys recall, that is one of the things that patients had the most concern about and that physicians had the least ability to manage. One of the reasons is that it's a real challenge and every person is very unique. So you can see there are lots of things that we can do. And really it's an individual process for us to figure out what's best for every patient. So this is something I encourage you to speak to your physician about. And there are a lot of things we can start to do, and we can see kind of how things go to try to improve your fatigue and how well you feel. So neuropathy is also something that is a big problem, as you guys well know, with the chemotherapy that we use to treat ovary cancer. So we have multiple medications that can help, but also remember that this is one of the things that tincture of thyme can help with a lot. And also remember that if you start on a trial of medications, it doesn't mean you have to take them indefinitely. That this is an opportunity to take something to see if it helps, and then to set a time-limited trial where you can decide, I'm going to wean off or stop these in 6 months or 9 months or a year and kind of see how things are going. So my tip number 4 is to review your medications and your health maintenance activities. So you can see this picture, and I know many of your medical cabinets look like this. So you can see all these different pills and all this different stuff. Some of it you may still be taking, some of it may be old, but you haven't gotten rid of it. It's exhausting to look at this, and I know that you guys feel the same way. So one of the things that's very important for palliative care and for you in general is the idea that you have all these medicines, but we should always be keeping a careful eye on what you're taking, and that what you're taking is equally as important as what you're not taking. And the idea of the deprescribing rainbow is using all of these different things to try to come to a happy medium, a decision about what you should be taking versus what you shouldn't. So there's a lot of different things that we talk about and we can ask. So I'm going to pull them all up here. Let me go back. So one of them is, are there medicines that are really important to you? If it's something that's important, we should keep it. Down at the bottom, are there medications that are a burden to you that you hate taking? We should get rid of those. And having an opportunity to talk openly with your doctor about what and why you're taking and what you don't want to take is really important. So it's also about cleaning up your medication list. And one of the things they've shown in the literature, I'm not spending a bunch of time plugging how great palliative care is, but in general, after a palliative care consultation, about 30 to 40% of your medicines may be able to be removed or reorganized, which may improve the ease of your medication regimen. And that's just important for your overall quality of life. So our goal when we deprescribe is to remove medications that have harms and uncertain benefits, and also the idea that a medication is a part of a prescribing cascade. So the best example of this is, say you have a medicine, you got a water pill because your blood pressure was high from your bevacizumab. And then you had to go on a bladder medicine because you were on a water pill and you were having incontinence. And then after that bladder medicine, you got a dry mouth. And so then you had to take another medicine for that. So you can see we've added 3 or 4 medications that in the end of the day, once you go off of the bevacizumab, may not be valuable for your care, but yet we may forget to remove them. So just thinking about things as they've occurred in your life and what really makes sense for you now. So that brings us to doing healthcare maintenance. So think about the things that we do that may be unenjoyable in medicine and whether these things are really going to help you right now, or maybe they're designed to help you even 10 or 15 years in the future. And thinking about whether that really makes sense for your life. So this is the idea that deciding what not to do is just as important as deciding what to do. So this applies to medications and testing. So we know that improving your mental health will actively help you now. And I know I'm speaking to the choir that these are the same things that you guys were just talking about. So going to counseling, spending time with friends and family, practicing mindfulness, we've all talked about these already today. So joining support groups, we already talked about the importance of exercise, and many other things, all these alternative therapies that we were discussing. So the last thing I wanted to bring up was the importance of treatment of a pre-existing mental health condition. And I don't know if we've already talked about this study. This was a beautiful study that was put out about a year ago. And it basically showed in patients with a pre-existing mental condition, if they got these treated, that it overall improved their length of survival with and without their cancer tremendously, better than many of the things that we can do with chemotherapy. So I wanted to highlight that. You can see that some of these patients live 25 to 30% longer just by treating and managing their mental health and getting support. So it's just so important in general for everyone, and particularly for our cancer survivors. So this brings me to the end of my talk. I appreciate you giving me this opportunity, and hopefully I helped to spark interest or something in you that you guys have questions about or that I can help you with. So thank you again.